Dr. Nurse Tutor. I am back with another tutoring session. This tutoring session will be geared towards my master's level nurses. These are the nurses who are getting ready to prepare for their AANP certification exams. Now, a little bit about me for anyone who is new to my channel and don't know really what deems me qualified to be a nurse tutor in certification exams. I have 15 years experience as a registered nurse. I am a med-surg certified registered nurse. I also have 6 years experience as a family nurse practitioner. And I have a PhD in nursing education with a postmaster's in online education that focuses on higher learning. I also have experience as a tutor where I tutor nursing students who are preparing for either their NCLEX or their AANP certification exam. So this tutoring session will be geared towards my master's level nurses who are preparing for their AANP certification exam. After this tutoring session, I will go back to my NCLEX tutoring sessions. I'll do a couple of NCLEX tutoring sessions because I have received some inquiries about when I will go back to NCLEX certification exam. So after this tutoring session, my master's level tutoring session, my next couple of tutoring sessions will be geared towards NCLEX preparers. So if you are preparing to take your NCLEX, just hold on. In a couple of days, I'll have another video geared towards my NCLEX prep students. Okay, so the first question is as follows. It is a 55-year-old male patient presents to the office for a routine preventative exam. The patient asked the nurse practitioner whether a prostate-specific antigen, PSA, screening is needed. Which is the correct recommendation? So you have a 55-year-old male patient who is coming in for a routine preventative exam, maybe a physical, and they want to know some information about when they should or if they should receive a PSA. The options are a PSA screening is not recommended in male patients aged 55 to 69 years old. A male patient aged 70 years or older should have a PSA screening. A male patient aged 55 to 69 years should have the opportunity to discuss the risk versus benefits of PSA screening. And the last option is a male patient aged 55 years and older should have routine annual PSA screenings. So I know for me, when looking at this question, the first thing that I want to do is what I usually tell my patients. I am big in preventative screening. So a lot of times with me, I will say, you're 55 years old, you need to get your PSA done and you need to get your prostate screening done today. Though that is not the wrong answer, that is not how you are supposed to answer these questions in certification exams. A lot of time when you're answering these questions is more so informative, is how you're supposed to answer the question so that the patient has more information about the importance, not only the importance of a PSA, but how often they're supposed to have a PSA done, and then give them the opportunity to decide whether or not if they're going to get the PSA done. So let's look at the options and see how we can find the best correct answer. So the first one says a PSA screening is not recommended in male patients 55 to 69 years old. So if you know what the age range is for PSA screenings, you should know that PSA screening is recommended in male patients between the age of 55 and 69 years old based on their family history, race, ethnicity, comorbidity conditions, and patient values and beliefs. Which basically the risk outweigh the benefits. Any male between the age of 55 and 69 should be having a PSA done. It's wise for them to have it. Now the next one was all male patients age 70 years or older should have a PSA screening. That's completely incorrect. The screening for PSAs for males are 55 to 69 years old. Usually after age 70, we don't really look into screenings for prostate cancer that often in those patients unless it's something that's requested, but it's not a requirement after the age of 70. And then the last one is all male patients. I'm sorry, that's not the last one. The next option is all male patients age 55 to 69 years old should have the opportunity to discuss the risk versus the benefits. And then the last one is all male patients age 55 and older should have a routine PSA screening done. That's where they're trying to trip you up. Because when I looked at this, I was like, yes, I will tell my patient all male patients age 55 years and older should have a routine PSA done. Though that is something that you want to do as a provider, that's not how you're supposed to answer the question. How you are supposed to answer the question is by saying, all male patients age 55 to 69 should have the opportunity to discuss the risk versus the benefits of a PSA screening, and therefore they can then decide whether or not if they want to have the PSA screening done. But you cannot, as a provider, you should not, as a provider, tell a patient what they should and what they should not be doing. You should be discussing the risks and the benefits of having these screenings done and why it's important for your patient to have these screenings done if they fall in the category of the preventative screening. So it's not more so pushing on what you feel your patient should be doing, but more so discussing the risks and the benefits of getting this done and why your patient would qualify for getting this particular screening done. All right, so the next question is, the nurse practitioner sees a middle-aged adult who has been diagnosed with polycystic kidney disease, PKD, and explains this condition to the patient's family. Which is the most common risk factor for PKD? Now, before even looking at the options, I want to make sure, you want to make sure that you understand what the disease is, at least have an idea of what the disease is before you answer the question. Now, I was fortunate enough to where I worked on a dialysis unit for about 6 years when I was a registered nurse, and I encountered many patients who did have polycystic kidney disease. So answering the question wasn't that hard for me as a master's level nurse because I was exposed to this patient population. But for those of you who don't know, polycystic kidney disease is an inherited disorder in which clusters of cysts develop primarily within the kidneys, causing the kidneys to enlarge, and then it loses function over time. So basically the kidneys become engulfed with cysts, and they just overtake the kidneys, and over time the kidney just loses function, and a lot of time those are the patients that need some sort of a kidney transplant. So if we're looking at the options are positive family history, African American race, female gender, prolonged intake of diuretics. So, of course, I gave you the answer. Positive family history is definitely a strong trait with polycystic kidney disease, but I like to look at the options and the rationale between the answers and why the answers are not the answer. So one of the options was PKD affects African American race. That's not the most common thing with PKD because PKD affects all races. Being African American has been shown to be a risk factor with end-stage renal failure due to PKD, and though we are pretty prominent as African Americans to get PKD does have the ability to affect all races. So that's not the most common indicator of PKD like how positive family history would be. Female gender is the next one, and since this condition may be an autosomal dominant or recessive trait, men and women are affected equally. So being male does increase the risk, because I will say that working as a renal nurse, the only patients who I saw that had PKD were my male patients. So there is some research out there that shows that male are a little bit more dominant in this area when it comes to PKD than women, but men and women can get PKD equally. It's just we see more male patients with PKD than we do see women. And then the last one was prolonged intake of diuretics. Diuretics are not a risk factor for developing PKD. Patients take diuretics for all types of issues. Though abusing them or not taking them as prescribed can definitely cause some damage to the kidneys, prolonged use of diuretics wouldn't be a huge indicator of someone who would be diagnosed with PKD, because we have patients who take diuretics for multiple reasons, whether it be high blood pressure or even some sort of a heart failure, whether it's a hydrochlorothiazide or if it's furosemide. So prolonged use used appropriately as prescribed by a physician wouldn't put you at risk for PKD, but abusing it or not taking it as prescribed could put you in some sort of a danger for some sort of kidney damage, but not PKD. So the best choice as an answer would be positive family history. So this next one might be a doozy for people because this is a skin question. I know when I was preparing to take this exam, skin was a big no-no for me because there's so many skin disorders and a lot of them sound the same and a lot of them look the same, and it's hard to decipher what is what. But honestly, exposure, studying this stuff, understanding and looking at things with pictures. I'm a visual learner, so looking at things with pictures was very important to me to understand what it was and how to treat it. But the biggest thing when it comes to skin questions is looking at what these things look like and then understanding what the treatment is. And another big thing is environmental, because a lot of times they'll ask you questions based on where the patient was or what the patient was doing. So we'll delve into this question and kind of see what they're talking about. This question is: an older adult presents with a rough flesh-colored lesion on the forehead that is tender. Which treatment does the nurse practitioner recommend for the concerning lesion? The first option is a topical corticosteroid. The second option is a surgical excision. The third option is application of liquid nitrogen. And the fourth option is 5-fluorouracil. A lot of these medications I can't pronounce, forgive me. And I don't even try to pronounce them. When I see them, I just know what they are. Okay, so this patient has a rough flesh-colored lesion on their forehead that is tender. The only clue that they're giving you is that this is a rough flesh-colored lesion on their forehead. A lot of times they'll be nice and tell you maybe the patient was working outside in the garden and they came in with the itchy rash, or the patient was out in the sun for a long time, if they want to be nice. Sometimes they won't. They'll just describe what the lesion or the skin ailment looks like and make you choose the options. Or they'll just throw a bunch of medications like how they did here. They didn't even tell us what it was, nor did they tell us anything as to how the patient may have developed this. They just gave us the description and then said choose the medication. So with this question, not only do you have to figure out what this patient has, you have to then decide what the treatment plan is going to be. So this is like a two-parter for you, because you can't answer the question unless you know what the patient actually has. So this is a rough flesh-colored lesion on the forehead, which is tender. So for me, usually when patients are given topical steroids, it's because something is either itchy or it's inflamed or it's swelling, and you need to calm the immune system down. It's some sort of a contact dermatitis or an eczema situation where you need to kind of quiet things down. This isn't really describing that, so I'm not going to say that I'm going to use a topical corticosteroid because it's rough, it's flesh colored, it's on the forehead, it's tender, and we usually do not put corticosteroids on the face. That's not practice that we do as providers usually. So those two things: it's not itchy, it's not inflamed, the person's not scratching, and it's tender. We don't usually use corticosteroids for anything that's tender, and we don't usually put corticosteroids on the face. So I'm gonna go with taking that out. Then the next option is a surgical excision. I don't want to cut anything off unless I know what I'm dealing with. Usually we don't cut anything unless you've done a biopsy and you've seen that it's safe to actually cut something off. The third one, application of liquid nitrogen, that's actually freezing. I'm going to hold on to that one because I kind of like where they're going there. Try to see if you can freeze it to see if it falls off, but I still need to know about this fluorouracil medication. Now, what I will do is I'll give you a clue because we need to figure out what this skin ailment is that this patient has. I've already omitted the topical corticosteroid and the surgical excision, but now I need to talk about what it is this patient actually has. And it looks like, because if we're using the fluorouracil medication and the liquid nitrogen, those two medications are used as treatment for actinic keratosis. Is usually used for treatment of and someone who has keratosis. If you're familiar with keratosis, keratosis are actually scaly spots or patches on the top layer of the skin. With time, they usually become scaly and hard and wart-like, and they're usually due to years of sun exposure. It's not really it's not to be confused with warts, and it's not to be confused with a psoriasis. I know some people may confuse this with the psoriasis because it says scaly spots or patches, but with psoriasis, usually they're nice enough and they say silvery patches. You always hear silvery patches when it has to do with psoriasis, because I was thinking that as a differential diagnosis, but when I saw the last two answers with the liquid nitrogen and the 5-fluorouracil, I was like, okay, looks like we're dealing with keratosis. Now, which one would it be? Because both of these medications are actually used to treat keratosis. How would you decipher? And I'm going to help you with that. The answer is application of liquid nitrogen, because of course I said each one of these answers would treat keratosis. The reason why it's not the 5-fluorouracil is because though that treatment is used for keratosis, that medication is only used when the person has multiple lesions present. So if they have multiple lesions all over themselves, then they would go with this fluorouracil medication to treat the keratosis. But if you have one area that needs the liquid nitrogen to freeze it off, to hopefully have it fall off, and treat the area, it's usually the liquid nitrogen. If you had multiple lesions, I can't imagine trying to freeze anything off with multiple hits of liquid nitrogen, because I could see that being a little uncomfortable. So though it's just one lesion, if it's just one lesion and it's keratosis, you're going to hit it with one application of the liquid nitrogen because it's one lesion, as opposed to if you had multiple lesions. So that one was a little bit tricky. You would have to know that it was keratosis. So my biggest advice to you would be to really study the skin ailments if you're not familiar and that's just not your strong area or your area of expertise. I would really say just study that stuff and understand, because a lot of skin ailments do sound and look alike, and sometimes the treatments may be the same. So definitely study the skin areas and understand the medication options and what is best practice for what lesion, because this question was really tricky, and if you didn't know what you would do for one lesion as opposed to multiple lesions, you could get this wrong and then you wouldn't even know why you got it wrong, because it's just tricky like that. Okay, so we have another skin question, which I'm actually happy about because skin tends to be the difficult area for a lot of people who are studying for this exam. So the question is, a young adult patient presents to the clinic with concerns about a skin infection. A lot of times patients are very helpful when they think they have an infection because sometimes they know, how infections present themselves. So just their history of what's going on can be extremely helpful. The patient reports no tenderness or drainage, which, we tend to like to see. So that kind of makes me sad because usually I want to see tenderness or drainage so that I can confirm that it is an actual infection. The patient reports no tenderness or drainage and states the rash started after participating in a wrestling tournament. Upon examination, the nurse practitioner finds plaques with crusting on the right lower leg. A culture is done and shows a Staphylococcus aureus infection. Which bacterial skin infection does the nurse practitioner suspect? I love this explanation because once I identified what this stuff looks like, I never forgot it. So like I was saying, there's no tenderness and no drainage, so that can be fearful or make a lot of people nervous when they need to answer the question. But pay attention to what they say next. They said Staphylococcus aureus infection on the skin. So let's look at the options. You got herpes gladitorum, you got hidradenitis suppurativa, you got impetigo, you got folliculitis. Herpes, you don't usually find staph in herpes, so I would hope that you would automatically just throw that out. Hidradenitis suppurativa, you may find infection and you can culture. Why that wouldn't be the option is there's no tenderness and there's no draining. Hidradenitis suppurativa, if you're familiar with that, that's usually when you have the large pustules that's between folds areas, and it's usually the armpits, under the breast, in between the groin area. This is on this person's leg. And like I said, hidradenitis is usually pustules that drain, they're funky, they're tender, all of that good stuff. Impetigo could be an option. And then there's folliculitis. Folliculitis is little pustules that come in patches, and you'll usually see that in areas where people shave. And it could be the legs, it could be the groin, it could be the armpits. It's pustules though. It's pustules. Sometimes they'll pop, sometimes they'll leak, sometimes they'll be tender. None of that stuff is described in what this patient is talking about. What he's talking about is plaques with crusting. You did a culture and you saw staph. The only option that I would say would make sense would be impetigo. The reason being is herpes is usually not plaques with crusting, it's vesicles. Hidradenitis suppurativa, like I told you, is pretty large boils that burst and they drain pus-like fluid, which this patient didn't describe. And folliculitis, they're like little pustules that come within the follicles, the hair follicles. And none of those things were explained from this patient. And impetigo, that's your honey crusted lesions that scale over, and they are usually infected with staph once you culture them. So that, I hope, was straightforward for you. If you don't know, please know. Anything that says honey crusted, or staph with no drainage or tenderness is usually impetigo. A lot of times they'll tell you that it's with children. That was a biggie for me. Whenever I saw it was peds or they would describe it that way, I would automatically know that it was impetigo. But this one, they tried to trick me and they told me that it wasn't a young adult patient. But even when they described what the symptoms were, I was able to pinpoint it. And I hope that I was very helpful, because herpes is painful, hidradenitis is painful, folliculitis is not always painful, but they are little pustule lesions that can burst and leak, whereas impetigo does not. So hopefully that was an indicator and that was helpful in you understanding what the answer to this question was. Okay, so the last question is, an adult patient visits the clinic for a wellness exam. On exam, the nurse practitioner notes a 6 millimeter dark lesion with irregular borders that are not uniform in color. Which should the nurse practitioner perform next? So your patient came in with a dark lesion and irregular borders. That should automatically stand out for you as to what it is you should be doing next. And I'm going to explain to you why based off the options that we have. So the first option is the 5-fluorouracil. Then the next option is liquid nitrogen. The third option is provide reassurance. And the fourth option is to recommend a biopsy. So I'm going to tell you off bat, any patient that comes in to see you and they have a dark lesion, a purple lesion, a red lesion, a yellow lesion, a green lesion, and it has irregular borders, you shouldn't do anything but recommend that we check and see what that is. Because anything that has irregular borders and is changing shapes and is changing colors, you need to look into it to make sure that it's not some form of a skin cancer. So do we need to be prescribing the fluorouracil and the liquid nitrogen? Honestly, no, because I hope that you will remember that I told you that that was treatment for a keratosis. And also anything with irregular borders, you don't even want to try a treatment plan because you want to know exactly what the heck that is. So the third option of providing reassurance should already tell you that that's not the option, because what are you reassuring? We don't have an idea of what that is. The only idea of what we may think it could be may be some sort of a skin cancer. So the only option that would be suitable for this question would be to recommend a biopsy. You want to biopsy what the heck is going on, and you want to find out as fast as possible. Now, with the question about the keratosis, why didn't we recommend a biopsy? Because usually the representation and the characteristics of the lesions will tell you exactly what it is. The only way we'll do a biopsy is if we are unfamiliar with what it could possibly be, or we tried treatment options and the treatment options didn't work. After treatment options, if they didn't work, then if you need to do a biopsy just to make sure that you're treating the condition appropriately, you can go ahead and do that. But usually if we know something and we're spot on about it, or we have a good feeling about it, we'll do treatment. And if treatment doesn't work, then we can go ahead and do a biopsy. But anything that comes in and is changing colors and it has irregular borders and is doing funny things, and you're not familiar with the representation or the characteristics of the lesion, you want to go ahead and do a biopsy, because the longer that you wait, the more that this has the possibility of getting worse. If you're not familiar with what is going on and it's changing, things like psoriasis, things like eczema, things like contact dermatitis, things like poison ivy, they usually don't change. They usually have the same characteristics. They may spread, they may become inflamed, they may be itchy, they may leak, things like that, which is fine. Those are the characteristics of those skin conditions. But something that's coming in and is changing colors and it has irregular borders, that should be the telltale sign of, I need to do a biopsy to figure out what the heck is going on and what this is and if it is cancerous. And also it'll tell you exactly what it is when you do a biopsy, but we don't want to go around doing punch biopsies on everybody. If based on the characteristic, you can identify what it is that this patient is coming in with. But in this condition with the irregular borders and the lesion is a dark color, doesn't even matter what the color is. If it's irregular borders, you want to go ahead and do a biopsy to find out what it is going on with this patient's skin. All right, everyone, so that concludes this tutoring session. Today we really went over a lot of skin issues and skin ailments that patients present in nurse practitioner offices with, and what the treatment options are. I did like this particular tutoring session because a lot of students struggle when it comes to skin ailments, what the presentations are, what the characteristics are, and what the treatment plan is. So I hope this was helpful. We also went over screenings, when to get your screenings, who's recommended for screenings, and how to talk to your patients about the recommended screenings that they would possibly need. And we also discussed a little bit about some PKD, the polycystic kidney disease, and who's at risk for that. I hope this tutoring session was helpful at helping you identify not only what's going on in the question, but what the treatment plan is going to be, because that is your job and your role as a family nurse practitioner. Now, if you did like this video, please like, comment, and subscribe below so that I can create more content related to AANP certification exams. And please, if you're confused about any questions that I presented, please leave me a comment below. I'll get back to you and we can discuss that a little bit more in detail. If you would like tutoring sessions with me, that option is available. Just leave a comment at drnursetutor@gmail.com. You can also follow me on TikTok and Instagram at Dr. Nurse Tutor. I will give you updates on when I will be posting new videos and when you can come in and see new content. But in the meantime, if you'd like to look back at previous videos to get yourself a better understanding about what the questions are going to look like on these certification exams, please feel free to scroll through. So after this tutoring session, I'm going to head back over to NCLEX land, and I will have a tutoring session with a couple of NCLEX style questions. So be on the lookout for that. But that is the end of this tutoring session. I hope you guys enjoyed yourself and be on the lookout for more content. Bye.